diabetes is a horrible disease for your eyes. It's the second highest form of blindness in Ireland.
Wow.
So after age-related problems, and age-related macular degeneration is not your fault.
But
we all get old.
Welcome to my podcast. I'm Tanya Corless, and today we're talking about optometry. I have a lovely guest, Hugh Nolan. Hugh is the head of the photography department at Royal Victoria Eye Hospital. Hugh has wealth of experience, and he leads his department through the capturing the image to the documentary. They kept all the documentation in file to be able to use for research and for the training. I'm dying to hear all the stories that Hugh gets through during his experience working in an eye hospital. Hugh, welcome.
Thank you very
I'm
much.
so glad to see you here.
Yeah, well, it's great to be here. It's been a while since we've spoken, and
Yes, 10 years, I
it's been
presume.
even more since we worked together. So.
That is true. Yeah.
So we basically in the Eye and Ear Hospital are kind of, because we're a centre of excellence, we get referrals from all around either Ireland East or anywhere really in the country, depending on what's wrong with someone. And our objective really in medical imaging or medical photography, as you'd like to call it, is to image someone's eye, especially I'm about 90% deal with just eye conditions, okay? So when someone has a particular diagnosis and they're referred into the hospital, we would do all the baseline images. So we would do wide field photography, or what's called OCT, or ocular coherence tomography, which is basically giving the doctors a baseline image of what a patient turns up with on that day.
Right.
So we would get referrals in from really everyone, but mostly from Ireland East, which is kind of half of Leinster, basically.
Wow, of course, it's area. Hugh, tell me about your background. What you was doing when you was 18 years old, and how you decided to be a photographer.
Oh, well, at 18, I had no idea what I wanted to do. I didn't really cop on until I was about 24. So after wandering around Ireland, taking up numerous kind of jobs that I didn't really want to do, I decided I'd go back to college. So I went and studied. First, I did television and audio operations in Ballyfermot College, which was I was a kind of a game changer for me, really, because it gave me knowledge of stuff that I always wanted to know about. And then you realize how difficult that job is, because I always thought television was pretty straightforward until you start studying it. Unfortunately, there wasn't a huge amount of work in it. So my family background is photographic based. My brother is a photographer as well. So he suggested that I go to DIT and study full-time in photography there. So I did, and I was pretty handy at it. I did very well. But when I graduated, it was hard to get any sort of work in photographic. So I did a lot of freelancing with a number of photographers around. But again, freelancing and assisting with people is a very poorly paid job. You're basically being seen as an apprentice, and you do what you can, and you kind of get as many jobs as you possibly could. But luckily, I managed to get a job in the College of Surgeons as a kind of a media person, doing projection, setting up audiovisual rooms, creating slides for teaching purposes, all that kind of thing. And Philip Curtis, who was the manager of the department at the time, who was also employing my brother at the same time, he gave me a big break. And basically, I then went on to be a press photographer. I used to work for a press agency and doing public relations photography, which was completely different to what it was photographic based, but it was nothing to do with medical photography until the photographer in the Eye and Ear Hospital decided to leave and go to Seattle, take a big job in Seattle in the US. So an opening appeared, and Philip and my brother Pat said, you should go for that. I had no experience. I had no idea what ophthalmic photography was about. Went to the interview, found myself like facing these people who were asking me all these medical questions, and I'm going, sorry, I have no idea what you're really talking about here, you know. So managed to, because of circumstances of the people who were before me and who had accepted the job and then who got upgrades and stuff like this, I ended up being offered the job. So when I went in, I had to start from complete base level of like picking up a book and reading about what all these specific cameras did, and also contacting all the sales reps who came in and basically said, oh, this camera works like this, it works like this, it works like this. And my mind works very much along the lines, as long as you show me how to do something, I get it, and then you just repeat that. And I was very lucky with the consultant who was over Photographic as well, Mr. David Mooney. He was very knowledgeable and very helpful and kind of trained me up. Because in those days, 26 years ago, it was all still, everything was being shot on transparency film or black and white film. So you had to be able to process all the film, mount all the slides, put all the names on it. It was very laborious and tedious, whereas now it's all digital and it's all instant. And doctors can, you know, within 10 seconds see an image that you've taken in another part of the world or anywhere, you know. So that's how I ended up in medical photography. It wasn't a chosen subject. Wasn't something that I always thought I would end up doing, but I'm 26 years doing it now, so I must like it, you know.
Of course. So tell me more about if, for example, tomorrow somebody will decide to be in this field. So what steps they have to take?
Okay, so primarily you need to be a qualified photographer. Now that's any third level qualification, and these are guidelines. These aren't, well, they're not even guidelines. They're stipulation by the HSE to work in medical photography in Ireland. We have to follow the HSE guidelines, and so you basically need to have some sort of qualification. That can be anything from a City and Guilds to a certificate to a diploma, and there's a number of colleges, DIT, do one, or I should call them TUD now, isn't it? DIT is gone, you know. It's Technical College Dublin, you know. And Technical University Dublin, isn't it? TUD, yeah, you know. And then there's Dún Laoghaire College as well, and the Institute in Dún Laoghaire, which have a degree course in photography, you know. So there are those kind of avenues, but unfortunately these courses don't teach anything to do with medical photography. Tommy Walsh in Tallaght Hospital, he's the senior in Tallaght Hospital, and Stephen Comiskey in the Ioneer Hospital have been trying to get some form of qualification or training, some formal qualification, but it's because it's such a small area, it's quite difficult to do. So what's happening at the moment is anyone that applies for a job or is looking for locum work or anything along those lines basically contacts us. We bring them in, see if they're interested, show them around, get them an idea of what's available. But then you have to go through all your Garda clearance and all that kind of, there's a whole load of paperwork that has to be done before you even get in the door, you know. So yeah, that's the basic qualification that's gone. In England, there is a setup for medical illustration. That's what we're called. Medical photography is now kind of deemed under the medical illustration, but that takes in everything from making posters to all sort of doing all forms of medical photography, like dental photography. Ophthalmic is part of it. And there's a huge range of that, like pediatrics is a whole new field. Pediatrics and photographing children, and especially newborns, all that kind of stuff. It's a very difficult area to be in. So there's all that to be considered. The course in England, unfortunately, is like 4 years long. So it's
Full
very
time.
full. Well, it's kind of you're working. It's kind of an apprenticeship where you're in college, but you're working for a hospital.
At the time when you're doing the course.
When you're doing the course. So you're getting paid as a junior photography, which is quite poorly paid in the UK, which is much better paid in Ireland. So it's easier to get a job in medical photography in England, but it doesn't pay very well. So it'd be very hard to difficult if you were like working in, say, Moorfields in London and living on a junior photographer in London, like it'd be very difficult circumstance. It wouldn't be easy, you know. So
and I'd like to say to you, thank you very much to have me there at the time when I was working with you. You taught me a lot of things, especially how to believe in myself.
Oh, that's very nice. Thank you very much. It's nice to hear that you train someone and you kind of get someone involved in a particular area of medical photography, and you've ended up now presenting your own podcast, which is something when you contacted me, I went, oh, that's where Tanya went, So, so yeah, everyone has different ways of getting into different lines of work. My particular way of getting into ophthalmic photography was very long-winded and very roundabout. I was a press photographer before I did medical photography, so it was a complete change of occupation, So
No, I remember when I've been invited to be trained there.
Mm-hmm.
So I was impressed of knowledge that you provided, that you are skills that you had, and tried to teach me everything. So, and honestly, it was something more than just a medical department. It was like a family. Because people have their cooperate with each other, people how they help each other, support each other. This was magnificent. That's my experience.
Yeah, well, the Eye and Ear Hospital has that feel to it. It's been great to work there. It's the only place I've ever worked for 26 years, So I bounced from job to job to job up to that. And yeah, the hospital does have a family, a large family appeal to it. Especially one of the things, when a consultant was retiring there recently, and he said, the Eye and Ear Hospital is a great place when people call you by your first name. They don't give you your title. They only give you your title when you're with a patient. So if I walk in and if there's a consultant talking to a patient and I have to interrupt, or I have to give him images, or I have to tell him where something is for that patient, I'll then say, oh, Mr. Power or Mr. Horgan or, Mr. Kilmartin or something like that. But if there's no patient in the room, you can walk in and go, hiya, Billy, how are you, Noel? And they go, oh, yeah, hiya, Hugh.
That's amazing.
So it's great like that. One of the things that I've noticed is that, especially in the photographic department, that when people start working with us, they don't leave.
That's true.
They leave for promotion. They leave to go to a bigger department somewhere else for more money, more prospects.
Different opportunities.
Different opportunities. So you get an awful lot of that. An awful lot of people stay in the hospital for a long time, and then it's also because of the training that we get, they're able to move on to other things as well.
That is true. The optometry center and on the on the chemistry, they work together with DIT.
Yeah, DIT has a whole particular section. So the ophthalmic course that is run through TUD is basically they get all the training that
there, and this is
there's a complete centre. It used to be actually, it may have moved because they've demolished Kevin Street College now.
Oh, they moved away.
I'm not sure. They may still be on the corner there.
Used to be there, yeah.
Yeah. So that's for the optometrists. That's great, and they get an awful lot of the training that we do as well.
Yeah,
so.
But they're providing the free of charge service.
Yeah, you can, because it's a training. You can actually you can go there for you can go training, there for baseline.
Yes, yeah.
So if you go in for, say, a wide field photograph, or you go in for an OCT scan, ophthalmic retinal scan, simple things, it's there for the students to operate the machinery so that they get trained up on it. So.
But actually, it's we need to talk about as well. Just quick, description. People maybe sometimes don't know, and they have to pay money where they can.
You can. You can get. Majority of the ophthalmologists out there have OCT scanners in their rooms now, because the price has gone way down, and there's different levels of OCT scanners, like everything. You can get your baseline car up to your Ferraris, so
that's true.
There's exactly the so there's all different levels, so you can get a basic scan in the community very cheaply now.
Very cheaply, yeah.
I think it's possibly €30 in Specsavers. I'm not sure. I don't work for Specsavers. I'm not sure what the cost is, but it's to get something which is up to this the only time that people went and got their eyes checked was when they were getting their driver's license, or if they had something wrong with them.
That's true.
If all of a sudden they noticed something, that was the only time. So you can actually get checked out in the community, quite well, because most OCT cameras will take a fundal image, or a fundal. What I mean by a fundal image is that's your fundus is the back of your eye, which is the retina, part of the retina. So a lot of them will do a baseline fundal image, and they'll also do a OCT scan. And an OCT scan, this is an amazing piece of kit that we have. Because an OCT scan, before it was invented, the only way you could get that scan was post-mortem.
Oh, yes.
So by taking the eye out, slicing it, and looking through the layers of the eye, right? When OCT was developed and has now completely changed ophthalmic.
That's nice.
Now you can see those layers in the back of the eye, and you can see them real time without any damage to the eye, or without any. You don't even have to be dilated. Like you can walk in off the street, have an OCT scan done, and you can find out how healthy your eye is in a very short space of time.
Right. I remember when I was working with you, I know you for a little while, and actually thank you very much to have me there, and I learned lots of things out of you. And tell me, at the time, I remember I was working only myself and you, and sometimes you had a locum. But how changed the department since then? I'm talking about maybe 10 years.
Yeah. Well, now we have 4 medical photographers working. Now, Sean works 3 days a week with us, but Rachel, Stephen and myself are full-time, Monday to Friday. We've had to change with the times, and it's constantly changing, because now we have wide field photography. You wouldn't have had that in your day when you were working with us. So wide field photography is a 180-degree view, one photograph. So you get an overall view of the back of the eye, which is brilliant for things like oncology or diabetic retinopathy. So in the old days, you used to have to take a number of different photographs, 5 or 6 different images. And you remember, like, the flash from these cameras is very bright, and it's very difficult for someone to focus on a particular light for a length of time. So the wide field photography now has replaced all that. But it's now got to the point where we're almost taking, 50% of the patients on this camera. So there's a huge amount of patients coming through the department now, which means there's a huge demand on staffing levels as well, which has been great in the Eye and Ear Hospital, because the hospital management group have really been supportive of us, because when they see the throughput and they see the waiting room packed with people, they go, we're going to need more staff there, because this is an area that's expanding, because we've, like, between the OCT scans and the wide field photography that we do, that would be 80% of our job. So there's a constant queue. So it's like a conveyor belt. It sounds terrible to say, like, with patients, treating them like a conveyor belt, but it really is. The camera's free, get the next one in.
Next one.
Get the photographs done, get the next one in, get the next one in. Because otherwise the clinics would just grind to a halt, So,
You're right.
So it has changed in a huge way, and that the different levels of, like, OCT 10 years ago was very basic. The quality was very poor. You basically had 2 lines. Basically, if there was any fluid or any changes in the back of the eye, you'd get an indication where it was. Now you can see every individual layer of the retina. You can pick out tiny little changes, which can preempt your diagnosis of, like, changes have started, therefore we can treat earlier. Whereas in the past, it was like you'd arrive in with age-related problems, and it would be, you'd get an idea of what was going on. But now the OCT is just state of the art. Like, it's actually to the point now where you'll see doctors, like, looking at layers going, is there a change there? And you're talking in microns, which is 1,000th of a millimeter, and it shows up these things. So the detail is amazing now, so every year there's a new camera, there's a new technology. Like, just recently we had our first handheld high resolution fundal camera, like fundal. So the back of the eye is the fundus, or the retina. There's lots of different medical terms for the same thing. But we did a trial on this camera, and it was like non-mydriatic, which means you don't have to dilate the eye. And we were able to handhold this camera and get really good images on people's back of the eye. And this is, and again, will make a big change in our work, because up to this, people who arrived who were, like, say, incapacitated, who were in a wheelchair or on a stretcher or stuff like this, we couldn't do. It was really limited. If someone had neck problems, you couldn't get them into the actual machine to take images. No. So the whole handheld instruments now will make a big difference, and they're trying to develop a OCT handheld instrument at the moment. So
right. Yeah. So from your prospects, again, based on your experience in this department, what do you think about the optometry service in Ireland nowadays? it's improved?
Now, oh yeah, well, because of technology, it's been able to improve quite a bit to the point that like small little things like most optometrists now or most like Specsavers, all things like that, all have OCT machines in them.
Okay.
So you're getting an awful lot of screening done in the community that was never done before. Like 20 years ago, we didn't have OCT for a start. Now the OCTs cameras that are out, you get a really high definition color image and you get a really high definition OCT scan. So anyone training someone to do OCT scan, do basic OCT scans is relatively straightforward. So that opticians, technicians, people in Specsavers, like just, you're getting an awful lot of community information coming in. So we get a huge amount of referrals in from optometrists, opticians, like if you have a business to sell glasses, you're going to be interested in doing these scans because you don't have to be dilated. You can get them done when you walk in off the street. Okay. So it's much easier for someone to get diagnosed or for screening. So like small little things like, say, diabetic screening, we got an awful lot of referrals from opticians and optometrists in for that because diabetic retinopathy affects you in such a way that you can have really good vision, you can have 6/6 vision, but your eyes are being completely affected by diabetes. You don't know it. You don't feel any better. You don't see any worse. It's until it starts, when it gets really bad, then you start getting problems. So it's not something that gives you lots of warnings. Okay. Like if you have like a detachment, you'll see flashes and floaters and stuff. There's a warning signs of it. Whereas diabetic retinopathy doesn't until you start getting hazy vision and by the time people turn up at, from first diagnosis, they can often be end-stage diabetes or they could have really bad retinopathy in the back of their eye. So now at least you're getting an awful lot of people scanned or an awful lot of people seen in the community and then referred to the eye near.
That's very interesting what you told us. Hugh, what you can and how you can describe your day-to-day routine. I think for people, they need to understand how the department operating because I believe people who is patients coming up and waiting for this long queue and thinking you just coming in one after another and they may be confused, maybe they don't understand why so quick and what you're doing and maybe they're asking you a question even. So how you will describe that? One example, one day of.
So one day, well, we open at 8:00, and we used to. It used to be a 9 to 5 job, but because of COVID, we had to then increase numbers because there was a huge backlog with COVID, and also during COVID, so that people wouldn't be sitting beside each other in the waiting room. You had to give specific appointments to people so that they were every 15 minutes from each other. So our day ended up changing from 9 to 5. We had to rotate all our hours so that one of us starts at 8:00, finishes at 4. One of us starts at 9, finishes at 5, and then I start at 9:30, finish at 5:30. So it gives a huge length of time so that we can pack in as many images as possible. So that's our kind of working hours. We generally almost from immediately that we open the door, we're starting work. And we would, as I say, we generally see patients from the outpatients, from theatre, from the wards, from the A&E department. There's a huge throughput of patients that come through us. Like over 20% of the patients that we see in the hospital come through A&E, and they all generally need imaging done as well. So you could have from any department, or like our biggest throughput would be from the outpatients department because we have I think there's 14 eye consultants. I could be wrong there. There might be more at this stage. So like today, we had oncology all day, so cancer clinic all day today. And that is huge input into imaging because you have to be able to tell whether a lesion is smaller, bigger, or staying exactly the same. So that is very heavy on imaging. And then all the AMD patient, AMD is age-related macular degeneration, which as we get older, and we're all living much longer than we were 50 years ago. So age-related problems are a big issue and one of the more challenging issues as well for the future. So we would depending on what's wrong with a patient would depend on what camera they're used, or depending on what we do a fluorescent angiogram, which you might have remembered as well, where you inject a dye into your bloodstream.
It was always
And
kind of oranges.
Really orangey, and you don't want to get it on your hands. You don't want to get it everywhere. It goes everywhere. You end up everyone thinks we're all smokers with this orange dye all over our hands. It looks like a nicotine scar. So we do this dye test, and that dye test takes, in general, takes 5 minutes to do.
That's so quick.
So but if you have to have the dye test, you have to have an IV line put in. Your eyes have to be dilated. You then have to go through the whole what's going to happen with the test. So it sounds like 5 minutes, but all getting the patient ready, the amount of members of staff that are involved to just get this one dye test done. So it's time consuming. Plus, in those 5 minutes that you're doing the scan, you can only deal with that patient. So doing an OCT scan in the background, someone else has to do that, and anyone that's forward. So an OCT scan should generally take a minute, maybe 2 minutes per patient, right? If they're cooperative, right?
Yes, okay.
But then you would get someone who say someone's very frail, they have Parkinson's, the head needs to be held, if they're wheelchair bound, you need to get them into a particular type of position so that they don't move or they're able. Yeah. So there's all these factors that you can't say like, oh, it should take, like, we should be, 40 patients every hour should go through the OCT machine. Impossible. It's impossible to say. Every day, depending on what patients come in, it depends on what you're doing and how long it's going to take. There's one particular test, which is ICG, which is and looks at the choroidal layer, which is the bottom layer of the retina. That takes 15 minutes to do. So if you have a 15-minute test, which again takes 5 minutes to put an IV line in, the whole preparation with someone. So depending on what the doctors want, depends on what we're doing. And we don't have an appointment policy. We have what appears on the day. We do.
How nowadays people who've been done surgery or who need to be diagnosed with something and get through all this kind of machine and talk to their optometrist, how people take care about themselves? Are they very strict to follow their instructions, follow their regulations out there? How do you teach them? How do you explain? Maybe it's not your part of the responsibilities, but still you probably come across. Yeah,
we come across it quite a lot. Small little things like you can give very general information to people. You have like, say take diabetes for a start. Okay, so diabetes is something that is, in my opinion, is kind of treated by, especially Irish people, as a bit blasé. Oh, it's just diabetes, So diabetes is a horrible disease for your eyes. It's the second highest form of blindness in Ireland.
Wow.
So after age-related problems, and age-related macular degeneration is not your fault. But we all get old, and as you get older, you increase the percentage of chances of having AMD. But there's small little things like if you're over 50, you can take a lutein supplement. Lutein is the coating, is the vitamin coating of the inside of the retina. But lutein is in high concentration in basic traffic light vegetables, as we say, red, greens, and yellows. Anything with a strong color in it. Okay. So peppers, kale, spinach, sweet corn, all those kind of things. And an awful lot of people don't eat vegetables, and especially with vegetables with lutein levels. So that's really good. So diet and exercise come down to a huge amount of it, especially health style. If you're obese, if you're not getting any exercise, if you smoke, smoking's really bad for your eyes because the small little particles in the toxins within cigarettes, and vaping is very bad as well. This is a whole new thing that's you're going to see in
young generation now.
Yeah, an entire generation, and it's just again, it's a form of addiction that you can make money out of. And it's legal to make money out of. Fortunately, I'm not going to change those rules. But again, with diabetes, alcohol there's a huge amount of sugar in beers.
It's effect, yes.
So all that information is you can give to a patient, but it's for them to interpret what they're going to do with it.
But they're good, do you think? They're good.
Oh, some are. Some people change their lives around, others don't.
Doesn't care.
Others
but
just
who
go.
will provide this kind of information?
It usually comes from the doctor, it comes from the social worker, it comes from the nurse. So there's specialised nurse screeners.
Okay.
So we have diabetic screening in the hospital as well now. So community referrals would come in for newly diagnosed diabetic patients, and then they would go to primary screening, and then we're a secondary screening. So if primary screening finds something, they send it to us.
About the consultant. So do you think it's enough amount of consultants there you have in the hospital itself, or maybe HSC needs to think how to bring more externally consultants who will be helping around?
Well, the fact that we only have, like, just for an example, we only have one oncology consultant in the entire country, which is Nolan Horgan. So they're certainly hoping to expand that service because he's absolutely snowed under, so yeah, you can, there's lots of different specialties that could be expanded. Again, it all comes down to finance because,
Absolutely, yes.
And I don't want to say consultants aren't cheap, but it's more the team that goes with consultants, because you need a registrar, you need a fellow, you need all the all the house, you have your SHO training doctors, because it's all training skilled so that they can advance in the career. And then you all need nurse specialists, medical photographers, radiographers, you know yourself, so there's a huge amount of team behind just the consultant, and there is a huge push into getting nurse specialists involved in the community as well. So now Ireland East is trying to do set up all these community services. There's a big one just after opening, ophthalmic one in Kilnamanagh, in Dublin, Loughlinstown, Greystones, all these kind of outreach kind of places, which will basically screen people, see them for the basic sort of things, so that you're clearing up the day-to-day kind of stuff that's in the Eye and Ear Hospital. So the Eye and Ear Hospital is for all the specialist stuff, or for all the difficult, controlled, bad management, all the, certain conditions need immediate attention, and you don't want them clogged up with the routine kind of stuff, so because the waiting lists are huge all over the place. Like the ENT waiting list or ear, nose and throat waiting list is huge, and that was partly down to COVID, because ear, nose and throat, it was right in there where COVID lived, and there was a huge amount of people got COVID who were surgeons and nurses, and they didn't survive, so there was now we have we have all the vaccines and we have all that stuff, but you got to remember when this wasn't there at the start, it was a terrifying thing. If you were a dentist or you were anything that was dealing with the mouth area, or the sinus area, At
the time I was working in one hospital and another one, it was sleaze, but you can feel that. So.
The one thing I have noticed is that an awful lot of people would have a go at the Irish Health Service. I think in very specific areas, and especially in ophthalmic areas, the people who are in charge of it are doing as best as they can with the resources that we have. Yeah. Okay? Now, there's always an expansion, but again, that all comes down to cost, and it all comes down to. But the future planning is to get more stuff done in the community, and then keep the centres of excellence kept to the specific stuff that is needed there. But then, if you're a patient for 40 years and you've been going to the Eye and Ear Hospital, and you have that whole reassuring, I'm going to the best place possible, and then you're all suddenly told, you're going out to an outreach, clinic where you're going to see a nurse specialist. And an awful lot of people go, no, I want to see the doctor, and that's just a culture and a historical thing,
I don't understand. It would be me.
Yeah.
Do you know why? I explain from the point of the patient view, and I feeling I'll talk to the nurse, explain myself, and then I have to meet the consultant doctor. I have explained the same things. I feel like I'm twice talking about the same things to different people.
Yeah.
Maybe behind of that, it's not really like that, but impression I have, it will be like this. I have one tricky question to you.
Go ahead.
So I know some consultants, doctors working in their INA hospital, right? But also they're doing their private practice.
Yeah.
So, and sometimes they will bring people who are able to get maybe under their government program treatments. They drag them in to the private section.
Yeah.
So
That is unfortunately, we do have a two-tier hospital system in Ireland. We do have the public service, and it's can be very hard to get into the public. We have a huge problem at the moment with backlog in surgery.
True.
So the NTPF scheme was brought in to try and get a backlog of, so they were getting consultants to work on Saturdays and Sundays to do private surgery, which is under the NTPF scheme, which is getting rid of waiting lists, you know. So
it's only because of the waiting list, okay? Not because the...
you can also, I mean, you know...
Again, it's a tricky question. It's, your
it's
own
not something
opinion,
that it's not.
observation.
I mean, like I'm not a doctor, so I'm not going to
Absolutely, yeah.
quote on what I think they do. You can see people coming to a public hospital who are private patients of
particular one.
Yeah.
Yeah. Okay.
That is sort of a chain of events that has happened. There's an agreement that they're under contract, you know, that they can bring in private patients into, and if that's your contract and you're legally allowed to do it, you know, I may not like it. I was always voted Labour and things like that. I was very much a working class kid when I grew up. So I always kind of, you know, had this kind of, you know, socialist kind of thing that everyone should be under a public system and it should be available to everyone, you know. So unfortunately, we don't live in that world. You know,
I know, but sometimes people think that, oh my God, if I'll be paying money, I'll be get better service, even if we didn't with the same doctors. Sometimes it's just psychologically people thinking, in my opinion.
Yeah,
also,
well, that's why there's private health insurance available. You know, so you can buy it. It's very expensive. You know?
It is, but it doesn't cover everything what you need.
No, it does, because it's insurance. Insurance is a very specific thing. It's one of my pets. Insurance is there to make money. It's not there to, you know, give you the best treatment.
Hugh, thank you very much for coming. Thank you very much to share, and I hope you enjoy our conversation and our time here. Yeah,
it was lovely. Thank you for having me. I've been interviewed a few times. It was much more comfortable, you know. So, I hope I've been of some help for people out there, and I hope people listen to this. It's been lovely to meet you again. Lovely to talk to you again.
Thank you. Thank you very much to staying with us. I'm Tanya Corless, and stay with us for the future. We'll talk about the health and insurance and everything what you come across in your life.